Welcome to TCN Talks, an Anatomy of Leadership. We continue the conversation in part 2, The Future of Hospice, How Hope Will Transform Reimbursement and Care, with our guests, Raianne Melton and Andrea Hale. And now, here's Chris Comeaux.
Well, as we go into our next segment, I want you guys, we've alluded to in the first segment about that hope is going to be able to enable us to go into value-based reimbursement. I'd like both of you to talk about that just a little bit more. I think sometimes anymore we hear value-based reimbursement, people kind of check out, been there, got the t-shirt. But doesn't value-based reimbursement just mean that it's pay for performance? It's ensuring quality ultimately aligns with reimbursement. And so I'd love to hear each of you kind of talk a little bit more how you might see that hope will help get us there and maybe how it'll actually work out. So Raianne, do you want to go first?
Sure. So it'll take a minute to talk about what CMS did with home health. And basically, they came up with 3 categories of measures. One was OASIS, one was claim-based, and one was the CAP survey. So what they've done is they've been refining it over the years now is, usually dyspnea, treatment of dyspnea is one of the OASIS-based questions. And they have a couple of areas where they combine OASIS answers into categories. For claim-based, they're looking at rehospitalization and ED visits. And then for CAPS, they've whittled down to just would recommend and overall rating. So if I put get out my crystal ball, knowing that I have no talent at all for forecasting, what we're going to be faced with is the hope questions will replace whatever the OASIS questions are. They'll be looking at symptom impact. And it's going to be interesting to see where we go with this because hope is only now in the first 30 days, whether for patients who are on 60, 180 days, what that's going to look like as we progress. So it'll have hope. It will have claims-based measures. And you may think, what is a claim-based measure for hospice? I really was looking at burdensome discharges in the Hospice Care Index. There's 2 categories for burdensome discharges. But now with that new SSBI, where they're really trying to target that out of the hospice Medicare spend, that's going to be interesting to see how that plays out.
Andrea, what would you like to add?
No, you got me thinking. I was several months, probably 6 months back, I was thinking of that trifecta that was similar to home health. And this is the difference then we're in the same 3 places, hope and the CAP score. But I was wondering with the claim-based if there would be something around acuity because they've been having us submit all the diagnoses that are related to the terminal prognosis for a long time. And I've wondered, is that how they're going to give us an acuity index? Because if you're submitting a patient for the claims and you have 2 diagnoses, but what they're asking for is every IDT to update that. So UTIs, respiratory infections, any symptoms in addition to diagnosis, then I was wondering if that was going to complete the trifecta and give the acuity measure. Because the acuity of the patients that we're caring for, I was just wondering if that was the other claim base.
Yeah, and I'm not sure how they would measure that in terms of, it's so easy because the claim-based in home health comes directly from Medicare billing.
Mm-hmm.
We submit it. We have to submit all the diagnoses. And not everybody's doing it. That's why I said never take that lightly. Like if Medicare is asking for something, there's a reason. Just like home health, they're going to look back at it and look at behaviors and it could predict your payment. So I'm like, we have taken the sickest of the sick. We have, our acuity is very high. And so how do you, if visits are similar, it's still not representing the acuity maybe, and visits could be the way they're going to do it. But I just always wondered about the diagnosis because if you don't have somebody that is painting a picture,
Well, you two are the experts, but it is interesting when we were at a conference together, Andrea, a couple of CEOs started sharing with me that they are now doing HCC scoring on hospice patients. And we know that, on the MA side, that's the language of MA, which is really kind of a comprehensive way of almost creating like a case mix index acuity. So there is that. I mean, you have HCC. We've not done it in the hospice space. It'd be a huge kind of learning curve for many of our organizations. The other thing, listening to Raianne, rehospitalizations, and we also know because of it wasn't SSVI, but it was actually, I did a podcast with Kim Brandt, who is the Chief Operating Officer of CMS. They're looking at those discharges of actual hospices, because we know some of the ones have not been doing the right thing, the collegiality, ends criminality stuff, large discharge rates. And so you could see maybe a combination maybe of all of that. I don't know if that provokes some thoughts on either one of your part.
Yeah. So when I was looking at the hospice care index, and this is something I'm also surprised at, we all know that we want to be 10, but very few people actually look. I found in my experience, very few people can really speak to what items are actually on them. And that burdensome discharge, where somebody is discharged, the first one is discharged and they're in the hospital or ED, and they return to hospice and then die in hospice, is different from the second level where they're discharged from hospice, go to the hospital, and die while they're in the hospital off of hospice care. So I think that that's really low-hanging fruit, especially, when we're looking at, is it like 23, 25% national discharge, live discharge rate now. So low-hanging fruit. And so, recommendation to all of you hospice leaders out there, understand where you're at on the hospice care index and which each item is.
That's well said. We did a podcast earlier this year with Bob Tavares and the gang on the measures that matter, and he talked quite a bit about some of those key measures. So listening to you both, I worry now about how bad the data is going to be, garbage in, garbage out. And that may just be kind of the way it rolls. Like maybe Oasis, it wasn't so good earlier on. So can you just both speak to that are we going to see a wide level of variability? I mean, just listening to you, I wonder how many people are really taking the time to go through those different chapters and define what do you mean by, like you were talking about dyspnea earlier. Are you concerned that the data is going to be all over the place, and is that going to harm us as a whole, or that's CMS is just used to that and they just keep on trucking going forward?
That's a loaded question, isn't it?
I think right now they're just focused on showing up, getting that, making sure they show up for that symptom follow-up visit, their HUV visits, making sure they're submitting the data. And then that, I think the biggest area of risk, and Raianne, you can weigh in, is how that symptom impact is going to play out as far as consistency. I think that's going to be, everything else is straightforward, but I really think that's going to be telling as to, even within the same organization, how people are answering those questions. Would be thought on that.
What would you add, Raianne?
You know what I would add? I think Andrea and I talked about this in our first meeting. One of my big fears from the beginning, as a nurse myself, and a nurse for many, many years, and working with a lot of different hospice nurses across the board, my concern was the underrating of symptom impact to avoid creation of the HUV. And, people often dismiss me, saying that hospice nurses are too professional ever to do that. But the reality is they're overworked, no work-life balance. Being a hospice nurse is not the easiest route to take in nursing. It's maybe the most rewarding, but it's certainly not easy. And even, having a subconscious bias to underrate that. And I am convinced that CMS is going to look at HUV utilization. And that's one thing that's going to get, from a survey point of view, is going to be a problem for people. So I would say that there's going to be data's going to be all over the place because there are going to be people who are treating hope as a form. There are going to be a group of people that have a lot of resources, or larger organizations who have the resources to really train staff, do the data analysis, be singularly focused on the outcomes. They're going to have better data. So, and I think that CMS loves it when we provide incomplete and poor data because it gives them an opportunity to make changes that are not always in the benefit of the industry, but might benefit in terms of reducing reimbursement.
So we should get really good at submitting the data then to prevent that.
Chris, I hate to interrupt. Can I add one thing? And it's around specifically pain. And we are taught, Margot McCafferty, pain is what the patient says it is. When you look at symptom impact, my dad is an example. If his pain was a 10 out of 10, he could be riding a tractor because he was so stoic and he was an iron worker and he endured pain all the time. So if you ask a couple of questions, how's it impacting your sleep? How's it? And my dad's going to say, it doesn't because but his pain is still a 10. Then that wouldn't trip that visit. And I was concerned about that, because then it takes away the pain is what the patient says it is if the impact isn't there. And I've been thinking about that a lot. And with new nurses that, well, when you get in the spaces of somebody has taken a lot of opioids in the past and, they're not responding like they're in pain. Well, there's reasons for that. And you're not experienced yet to understand that. So don't dismiss that and not address the pain because the impact doesn't seem to be there. So that specifically around pain, and that's the cornerstone of what we do. That was that. I'm glad you brought that up. That's where I want us to just keep working with CMS. I mean, this is our opportunity to work with them and provide them feedback. They've been very, get on their website and you can provide feedback to things and be part of this, help create this tool that's going to provide better end of life care for everybody who receives it when they do their quality.
Andrea and Raianne, I'll send this to you and follow up. Just listening to you, Andrea, there was an article that Court and I had highlighted in top news stories of the month earlier this year, because in Europe, they use a red, yellow light, maybe orange. It was red, orange, yellow, whereas the patient's perspective of where they want to be. I know, like we may say, okay, Chris, what's your tolerable pain level? But there was some wisdom in actually how they used the actual kind of, it wasn't a stoplight because it was, I think, green, orange, and yellow. I'll forward that article. I'm not sure if either one of you are familiar with that, but I found that kind of fascinating because it's from the patient's perspective that's making the clinician look at, not just like we're trying to hit some measure that, your pain went from a 7 down to a 2. Well, what is their perspective in it and where they want to be?
And that's perfect because that is part of a complete pain assessment. But when you do not do a complete and you just ask them their number, but you don't say, what is your acceptable? Because you can have a pain of 10, but your acceptable level is 6 because you want to be more alert and you want to be able to communicate, then that's the goal. That's the goal. And it still might be in that moderate level, but it's what the patients, like you said. So, but some pain assessments aren't complete, and that's it has to be complete, the type, their goal, and, those conversations. So yes, that is a main point in your pain assessment is understanding from their perspective what's acceptable.
Raianne, let me ask you, what gaps do you maybe concern you on the technology side? I mean, it's interesting to ask you, you work in a technology company, but the fact that you were teaching all last year on this, where do you see those gaps that are maybe going to prevent or create friction for people to accurately capture the HOPE data?
Yeah. So I think that the biggest gap isn't the collection of the data. I think it's making it actionable in real time. If your staff is not doing point of service documentation so that everybody on the team is aware what those HOPE scores are, especially around symptom impact, you're failing the patient. So I'm just going to say, whatever tool you use for documentation needs to have the ability for your team to do point of service documentation. So not only is it more accurate, it also, it's going to inform the plan of care, but it's also going to improve your nurse's work-life balance. I always said, if you're not doing point of service documentation, don't talk to me about your work-life balance, because it's going to be more accurate if you're there in the home. Also, you need to have, hopefully, access to data analytics that is going to show you how you're trending. And I think that's going to be super important as people move forward. Having the assessment as part of embedded in the visit as part of the normal workflow is essential. So that just to make it happen and make it happen accurately. And having that data linked to easily update the plan of care while you're there. One of the questions, we're always asked by surveyors, they'll ask the patient, did you participate in development of your plan of care? If you're updating your plan of care at the visit and you say, we're going to update your plan of care now, you're going to have improved scores. So I would say that if you're using an electronic medical record, hopefully you are. If you are, make sure you're using it to its full potential and that you haven't created workarounds because you don't understand how it functions properly, because that delays everybody, and you're not going to get the accurate data from it.
Thank you. Andrea, what would you add?
Agree. Point of care documentation. With that said, the clinicians' barriers to point of care documentation are thick. If you open up your laptop, you're trying to sync, you have cumbersome little text boxes that you're supposed to go in and out of and engage with the patient. We're asking too much. I go back to this, Raianne. 22 years ago, I had one piece of paper to do my physical assessment on, and admission was a trifold. People are dying the same way they were 22 years ago. The meds that we're using and how we're doing it are pretty similar, but we have complicated this so much at the point of care, and we want them to do more and more, and how many fire extinguishers and this and that. And it has to become less burdensome for them. Because there's enough pressure to be there with this family and they're losing their loved one and all the stress. So I challenge the EMRs, make it so easy at the point of care. Like I have a notebook, and then just like I have that one page, like that's still the way we assess the patient. But now it's 18 pages of an admission assessment. And I'm saying, for what? And you want us to sit in there and do these 18 pages. How do we make it so user-friendly that they feel like they're not burdening the family on admission, especially 2 hours of their precious time, and still getting that information? And I don't know that we've solved that. And we're in Suncoast, and I talk to colleagues all over the country, is how do we make that so easy for them, I'll say.
Seamless. I'm going to say seamless.
Seamless, because before I retire, my goal is to not have any citations for care plans. Because they're just out there, disconnected. You're in there doing your thing. You're managing the plan of care, but they'll get it one way or the other. You're going to get a citation because they're just disconnected. So how do we make that so seamless for them? And that's the word, that it's possible. It's really possible.
We're just about to launch at Access our ambient listening model. And I'm really very excited about this. I think it's going to require quite a bit of retraining, because as we're asking the questions to the patient, the ambient listener, which, even though I work for a technology company, I don't have a lot to do with technology, is going to frightening, isn't it? What we're going to be doing is it's going to be pulling out that essential data and automatically entering it in for you. And then it will also create the narrative. Now, it's always got to be human forward, right? Human head in charge. So, the nurse will have to go through and, validate that it's correct. But I think that probably ambient listening is going to be the one thing that is going to really support that accurate documentation and timeliness, and make us feel that we we've done it quickly because if it's we don't have to just talk it and then write it. It's all happening at the same time.
And write it in 20 different places. It's actually listening and trying to put it in that way.
Of all the things that we've talked about in AI ambient listening is when I went that. If we can figure that out in a way that supports these clinicians at the bedside, that they feel confident that all that's being captured, it will lighten them so much. So you nailed it. Like that is the space of figuring that out. You get accuracy, you get work-life balance, and I think that's a main part of the solution. Sorry, I didn't mean to interrupt, Chris, but I was excited that you talked about that.
Let me ask you guys one final question and then give you the opportunity for final thoughts. If either one of you was advising a hospice CEO today, how are they and how should they balance these near-term financial pressures like, the wage index stuff that we just started, especially if you got areas where you're getting wage decrease due to the CBSA, when you got inflationary expense pressures. But then you also need these longer-term investments required to be able to compete in a hope-enabled, value-based environment. What would be your recommendations to them? So, Andrea, would you like to go first?
What I've been focusing on is, there's a lot of distractions right now, more so than I've ever seen in 22 years. Like all these predictions of what might be and what needs to be, and you just kind of get frozen in it all. But when you stay focused on your mission and your organization, and you start digging into the areas, the mission support areas, right? The places in MVI where you can look at your net patient revenue and make sure that you're lean in all of those places. And if you need support in those places to figure that out now and get lean and make sure you can invest in your clinical support at the bedside to be able to, provide the caseloads for these clinicians that it's possible for them to show up every time they need to show up and get their caseloads down so they can have work-life balance. Because if we can't continue consistent workforce and start teaching the next generation, it doesn't matter. So the more lean you can be on those mission support services in all those areas and your operating margin, that's where I've been trying to focus with all this going on, and quality, and just doubling down on that. That would be my suggestion.
Perfect. Raianne?
Well, I don't think it's an either or problem. It's a sequencing problem. And, if you look at the short-term goal of cost control, for instance, that's going to buy you time. You're not going to want to you don't want to shrink your organization into irrelevance. You need to be very targeted, protect core clinical talent and quality infrastructure. And then at the same time, be aggressively attacking variation, inefficiency, and non-strategic spend. That's so important. And looking at productivity and standardizations, not blanket cuts, which is in the long run is going to hurt you. And at the same time, you need to be investing in things for your future that are going to make a difference. What EMR are you using? The cheapest is not always the best. It'll work for you, but how do you, get the tool that is going to really support your growth, compliance, and meet all the regulatory components, as well as support your team in better work-life balance. So the few non-negotiables are clean, reliable clinical data, consistent care pathways, and engaged clinicians who understand outcomes, not just visits. So that would be my takeaway.
That's well said. I did a podcast a couple of weeks ago, and originally, Andrea knows this, we had done research and came to the conclusion there are 8 challenges facing all hospice and palliative care programs. And I was working on it one night. My wife said, "What are you doing?" And I told her, and she goes, "That's depressing." She goes, "You got to give people hope." And so long story short, we came up with this really kind of sticky kind of prescription. It's just broad categories. You should grow. You should know. you need to sow and you need to flow. And so those 4 category areas, and you really hit upon all of them in what you just said, Raianne. Well, I want to give each of you the opportunity because we really have covered a lot of territory in this, and it's going to be so interesting to see where Hope is going. But again, why I wanted both of you is you are so foresightful. I always kind of make the joke that, the Centers for Medicare and Medicaid Innovation, they're doing great work. But CMS is not exactly all that innovative. You just look at what they've done to other parts of healthcare, i.e. home health. They're going to do it to us at some point in time, which is obviously a lot of the premise of this. So what final thoughts would each of you like to share? You've got the ear of hospice and palliative care leaders. You're both incredibly knowledgeable about this area. So what are your final thoughts? Raianne, would you go first?
Sure. So when I step back and look at my 20 years in hospice, I always thought home health nurses were if I was in school, they were the preppy kids. And the hospice nurses were the hippie kids, which really worked well for me because I've always thought of myself as kind of a hippie. And now we've always thought that our reputation and clinical instinct were the most important things. And that's not disappearing, but it's no longer enough on its own. And the future buyers of hospice, whether it's Medicare Advantage, health system, patients, they're going to expect hospices to prove their value, not just assert it. And for a long time, because what we've done, we've just said, we're the cool kids and we do it well and we know what we're doing, but we never really provided the data. We didn't always provide the data to support that. And I think that moving forward, we need to think about how we message that we're still the cool kids providing a specialized kind of care, but we have data to support it.
That's very well said. Andrea?
It's similar to how I was going to sum it up. Now, imagine that. The data comes first. The data comes first. Understanding it comes next. And then the payment is going to follow. And if we can get comfortable with, now we have the data. We've always had the stories, right? We've always had the stories, and the community support is a cherry on the top, that they just come forward with gifts of philanthropy because they love the care that they received and they want us to do more of it. So if we just get more comfortable that yes, we got to give a little bit more data. We've always done it, and now it's just, this is a tool to help us do it. And then we'll understand it. And when we need to pivot, we'll pivot. And then we're going to get paid based on how wonderfully we do and have done. And the only thing that I would add then is, we've talked about the value-based care and taking risks. And I've thought about, and I've had this conversation with Chris, we're really the OGs on taking risks when you look at hospice, because we were given, let's just make it up, $4,000 a month to care for somebody. And you take them on, and then they may add treatments to their plan of care that are beyond that $4,000. We're managing risk all the time. Then when you became open access, trilogies, milrinone, TPN, all these expensive types of treatment came about. We're managing that, and we're not sharing in any savings. So we've always done this. We've always, not full risk because we're not responsible for hospitalization and everything, but we are managing risk all the time. And I think when you are a nonprofit and you're taking the highest acuity and you're saying yes to every patient that comes to your doorstep, that be confident, and you've been doing that, and now you just need to take it to the next level. Taking it to the next level. It's not like we need to throw out the baby with the bathwater. We've been doing it. We just haven't been calling it that, and especially when they said virtually all diagnosis related to the terminal prognosis, and you are covering everything but maybe some glaucoma. So all of those meds and all of those treatments, that this is where we're at, and now we're going to get paid for the quality. So it's exciting and terrifying in the same sentence, but I think it's necessary, and we're in this together. So, and I love having partners like Raianne who will help us solve those problems, like, charting at the bedside, because this next generation isn't going to have it. They're not going to, even if they could document at 9:00 at night, they're not. And I applaud them for that.
That's well said. Andrea, I'm just reflecting on what you're saying because I know you well enough that, you know that we're not getting the penalty, but what you're saying is we've been saving the money when you actually look at it. Even the studies that included mediocre, even horrible hospices still saved a lot of money, and that it shouldn't worry us that we're going to be at risk. If anything, just listening to both of you and thinking about it, like getting it dialed in the education, you should then be in the top tiers. And if you're in the top tiers, that's where typically Medicare say, congratulations, we're going to give you an add-on. If you're mediocre, you get whatever the national rate is with your CBSA. But if you're below the 50th percentile, guess what? We're going to take money back. And the organizations that should be fearing that are not even thinking in terms of what you've been weaving throughout this whole conversation. So kudos again to both of you. And Raianne, I love what you said. I just finished this weekend. It was actually through a good friend that Andrea introduced me to. Had him on the podcast last year, Dave Mastovich with No BS Marketing. He had a meeting with our TCN network and he said, you guys should go and read The Whole Story, which is about Whole Foods, which is so fascinating because I totally get now what he was poking on this. Whole Foods were the hippies about the whole healthy eating kind of movement. And now everybody wants a Whole Foods in their community. And this is where Andrea comes in. Andrea said for me for a long time, Chris, the baby boomers are going to want the best of the best. We've created a beautiful model of care. We have to talk about it differently so they realize, what I'm thinking is listening to you two is we need to create the Whole Foods brand, that they realize this is the best of the best, but when it comes to serious illness care, this is the type of organization you need to get care from, which is what Whole Foods did for healthy aging. We need to do that for the seriously ill space. I don't know. I know I told you final thoughts, but if that provokes anything from either one of you, any final comments from either one of you?
You don't need to put it on the podcast, Chris, but with that baby boomers and my big brother's 18 years older than me. So he tells his friends when they need hospice, he has this bucket list that, he'll go, you ask them their star rating, and if they don't have one, go, no, thank you. And then you ask them if they have a care center, and what do you do if your loved one can't be managed at home and they have a crisis? Do you have it then? If you don't have a care center, do you have a contract with your local hospitals to provide that? What happens? And what's the third one? He has a third one. So he has his own little baby boomers checklist for his friends that they know that his sister does hospice. So then they'll ask him, but I got to figure, but that's it, boiling it down to them to weed out, because they'll have all these providers coming to them. But what is quality?
How do you know we're getting the best of the best? Ladies, thank you for both of you. You just did a tremendous job. And we could go 2 hours. I should probably do long form podcasting. Just very few people will listen to the full 2 hours, but you two could keep going for 2 hours. Thank you for the work that you're each doing. And to our listeners, we thank you. At the end of each episode, we share a quote, a visual. The idea is to create a brain bookmark, a thought prodder about our podcast subject to further your learning and growth, and thereby your leadership. We're hoping it sticks like a brain tattoo. Be sure to subscribe to our channel. We don't want you to miss an episode. Check out, if you're interested in my book, The Anatomy of Leadership. It's easy for us to rail against the world and be frustrated by things. Let's be the change that we wish to see in the world. So thanks for listening to our podcast, and here's our brain bookmark to close today's show.
Hope becomes the shared clinical language that drives real-time decisions. By Raianne Melton. Thank you, USI, for sponsoring this podcast.